Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing cholesterol, often referred to as one of the numbers you should know about your health. We'll talk about those numbers, what they mean, and why they're important, along with a lot more. My guest is my colleague, Dr. Benjamin Hirsh. Dr. Hirsh is the Director of Preventive Cardiology at Northshore University Hospital and an Assistant Professor of Cardiology at the Zucker School of Medicine. Ben, welcome to Well Said.
Thanks for having me, Ira.
So let's get started at the beginning. I want you to explain what cholesterol is and what its natural function is. What is it supposed to be doing in our bodies?
Cholesterol is a type of lipid called a sterol. So it serves as a precursor to steroid hormones that we all need in our bodies. It's essential for our bodies and tissues to function. It's an essential component of cells and their structure. And again, essential for production of hormones. Interestingly, contrary to popular belief, we make more than enough cholesterol in our own cells and tissues. So I often get asked the question, but doctor, don't I need a certain amount of cholesterol? The answer is yes, but we make plenty of it on our own and actually get a fair amount from HDL. So we really don't have to worry about lowering the bad or LDL cholesterol too much.
Yeah, we'll get to those good and bad and the numbers in a minute, but I just want to dive into some of the things you just said. So you mentioned the word lipid. So what is a lipid? That's a fat, right?
Right. So lipid, they're a subgroup of basically fat. So they encompass triglycerides, fatty acids that you consume, as well as cholesterol. So it's kind of all of those three things.
And you said those naturally occurring fats are circulating in our bodies, and when you said they're the precursor, you mean there's something that our body uses to make other important stuff, right? Like hormones and other chemicals that we need for normal, healthy living.
That's correct. They're kind of the building blocks to produce the hormones that we need to regulate all the functions, many functions in our body.
You mentioned that we often talk in sort of shorthand about good cholesterol and bad cholesterol. Can you sort of straighten us out about what those are and why some are considered good and some are considered bad?
So like we talked about, lipids are, these fatty acids, triglycerides, cholesterol, are carried by proteins in the blood. And it's really the concentration of the proteins that determine the amount of good and bad cholesterol in the blood. The two primary proteins, HDL, the good protein, and LDL, are what people most commonly think of as the good and bad cholesterol. HDL is the good cholesterol because its primary function is to take cholesterol from the arteries and deliver it back to the liver or to other tissues that need it. The bad protein is called LDL cholesterol because it carries the cholesterol into arteries. This sometimes doesn't tell the whole story because the truth is that any protein that's not HDL can really deposit lipids and cholesterol into the arteries. So that's why we sometimes look towards non-HDL to capture all the bad cholesterol-carrying proteins, including LDL, that can be harmful.
Is that also why you can't get the total cholesterol from just adding the HDL and the LDL?
That's exactly right.
And so each of those is important in its own right, the HDL, the LDL, and the total, but for different reasons and in different ways. Do I have that right?
That's right. And, people tend, just as a kind of a side note, but people tend to focus on numbers. So people say, oh, your HDL is 70, but they may have a family history of heart disease. And even though the HDL is a good number, it may not be functioning as good as others. And so people shouldn't always assume that just because they have a good cholesterol, it outweighs a high bad cholesterol.
Yeah, and we'll get to some of the numbers in a minute, but I just want to reinforce what you said a minute ago, that the HDL is the good cholesterol, so that's one where we want to see, in general, a higher number, and the LDL and the total cholesterol are the ones that are associated with bad things happening, and we want to see those numbers lower, right?
That's exactly right.
So you said our bodies make cholesterol, but it's also influenced by what we eat. And I guess how much we make is influenced by our kind of genetic makeup. So can you sort that out a little bit? Which is more important, who we are genetically or what we eat?
So again, the amount of cholesterol in our blood is actually dependent on both our consumption of fats and cholesterol, which again get packaged into these proteins that carry them. And then it's also based on our body's enzymes and our ability to release the cholesterol from the proteins that carry them. So it's important to recognize when there are abnormal enzymes that lead to excess LDL and triglycerides, that could indicate a genetic abnormality. And this leaves a significant amount of cholesterol in the bloodstream. And in those kind of situations, we really look towards medicines to prevent heart disease and strokes. At the same time, an excess consumption of cholesterol also can lead to similar outcomes. And so addressing a patient's dietary habits is really essential to improve their heart and overall health. And but both circumstances, it's just whether or not you're consuming a high amount of cholesterol or you just have some problems in your cholesterol metabolism can lead to the same outcomes.
In a given individual, is it clear that one is more important than the other? Or let me rephrase that. In general, is the cholesterol level more closely influenced by, who we picked for our parents or what we put on our plates?
So I guess in a given individual, I would say as a whole, there is probably more of an influence from genetics. That being said, it can, and we do see this a lot, especially when it comes to triglycerides, it is influenced a lot by our dietary habits and our lifestyle.
Yeah, so let's turn to diet then. You mentioned that you can raise your cholesterol level by eating foods that have cholesterol in them. So I have two questions. So what kinds of foods have a lot of cholesterol in them? And the other question is it only foods that have cholesterol that raise your cholesterol?
I'll try to make this a little bit simple. Essentially, foods with high content of saturated fats, these are the bad fats, can actually, even if their cholesterol content itself isn't too high, it can signal your body to make more cholesterol than it needs. And that can lead your body to have a high cholesterol content. So it's not only that your food itself has to contain a lot of cholesterol that leads to high cholesterol levels. So to answer the second part, which kind of ties into the first part, for example, foods that could raise cholesterol, again, include these higher amounts of saturated or as I'm sure you've heard about, or we've all heard about, trans-saturated fatty acids. And those are things like, red meat, cheese, ice cream, butter, coconut oil.
Are there other, I'll say, non-fatty foods that can also raise your cholesterol levels?
So there are other non-fatty foods that can raise your weight and your triglycerides in particular, and that's kind of these carbohydrate-heavy diet, especially the kind of refined carbohydrates we get in a lot of the food that's in plastic bags, such as pretzels and candy, and this can be, and these can turn into triglycerides and also have been linked to high rates of heart disease. So certainly, it's not all about fats. If you're replacing a lot of those fats with carbohydrates, that can lead to higher triglycerides and cholesterol.
And that's interesting. Is it mediated through increased body fat? In other words, if you're eating a low cholesterol but high sugar content diet, but you don't gain weight, can you still raise your cholesterol levels?
They can raise your cholesterol even if you don't get fat, but It's not necessarily kind of a one-to-one relationship. They can raise the amount of triglycerides you have, which ultimately, when your body sends out or packages these triglycerides, they send out more cholesterol with it. So regardless of whether or not you get fat, you can still get a little bit more increase in cholesterol. It's not as much as with direct consumption of these saturated fats, but it still has an influence. And more importantly, it does have an influence on other things in your health.
Sure. So we talked about saturated fats, obviously cholesterol-containing foods, and the little more complicated story about these refined carbohydrates. Let me ask you one more question about that before we get to kind of, quote, good foods. What kinds of foods have high cholesterol content directly as opposed to indirectly through other fats?
One of the things you'll hear about commonly is eggs. Every week you'll read about some expert telling you how many eggs you can have per week.
Right.
And that's it. It's almost like that's the magic bullet. And if you eat only a certain amount of eggs, you're fine. Just like if you take a fish oil, you're fine. There's only one part of the story. But regardless, just to kind of answer the question, things such as eggs are kind of high cholesterol content foods where your body absorbs cholesterol directly. But as I said, that's just one part of the story because these other saturated fats can also produce cholesterol, even if they don't have high cholesterol content in and of themselves.
Some of these other foods that get labeled as having a lot of cholesterol, I'm thinking about shrimp. Is that real?
So shrimp having high cholesterol, well, what I'll say is I'm not sure that it does have a higher cholesterol content, but they do have some, good fats in them. So, I think that your overall approach to diet should consist not just of focusing on cholesterol in and of itself, but that's just kind of one word that has become an umbrella for fats in general, but really focusing on the content of the good fats versus the bad fats. And shrimp's actually not all that bad for that, assuming it's not fried.
Fair enough.
Mm-hmm.
So we've been talking about some foods that can raise your cholesterol. Are there dietary patterns or particular foods that can lower your cholesterol?
So basically anything that delivers, a high soluble fiber content, which binds cholesterol, or plant sterols and stanols. So to give you, which block the absorption of cholesterol. So basically, to give you some examples, things like legumes, which are like lentils, soybeans, or oats, certain fatty fishes, leafy foods like spinach, vegetable oils, canola oil, olive oil, certain nuts like walnuts. These are all things that have higher contents of the good fats, the monounsaturated and the polyunsaturated fats, and have been shown to lower cholesterol.
So let's get into kind of the effect of cholesterol on the body. I think it's fair to say it's widely understood that having a high cholesterol is considered a risk factor like high blood pressure or diabetes that can increase the likelihood of plaque buildup in arteries, which, as you said, can lead to things like heart attacks, strokes, kidney failure, other horrible things. What's the mechanism of action there? So what's the connection between having an elevated cholesterol and having your blood vessels harden or deteriorate?
Basically, again, the excess cholesterol in your blood is carried by these proteins. And these proteins, such as the LDL cholesterol, what we commonly refer to as the bad cholesterol, can get into the walls of the arteries, and through a process that's very detailed, ultimately the cholesterol within that protein crystallizes and plaque forms. Over time, the more and more plaque that forms, it starts to weaken the integrity of the wall. A blockage starts to form inside the blood vessel. And sometimes, if that blockage or if the amount of cholesterol content continues to grow, it can weaken the wall to the point that it ruptures, and that's when we get these heart attacks or strokes.
And so the cholesterol actually builds up inside the wall of the artery.
The cholesterol builds up inside the wall of the artery, exactly. It's consumed by some other cells that ultimately form these plaques, but yes, it does get deposited inside the wall of the artery.
And a question that's often put to me when I'm talking with patients about blockages in their artery and the relationship with cholesterol is, can you reverse the clock on that process? Meaning, can you lessen those blockages and actually kind of remove cholesterol from plaque in arteries? What's your answer to that?
What I would say is that there have been studies that have shown when they've gone in with tiny microscopic ultrasounds into the arteries that over time, if you lower the cholesterol with medications and get it down the LDL to very low levels, you can reduce the volume of plaque. However, that's more of an academic study type thing, and it's not something that we would follow on a routine basis. What I would say is that we can stabilize the plaque with certain medications, and in that setting, and in combination with just better lifestyle, prevent or at least mitigate that risk of plaque progression greatly.
Okay, and honestly, that's really kind of the name of the game, right? We don't want those plaques to become unstable, cause a heart attack, cause a stroke. So if you can stabilize the plaque, that's a very good thing to do.
That's exactly right. I mean, we worry about these plaques becoming unstable, and a lot of these medications can really interfere with that process and make it much less likely that they rupture. I
do want to get to some of those drugs and other treatments. I mentioned at the beginning that a lot of organizations, I'm thinking like the American Heart Association and others, have pushed this idea that people should know their numbers, meaning not just know the kinds of things we've been talking about, but also know that their cholesterol level is a certain value. Can you give us a sense of what those numbers ought to be and whether we should all be aiming for the same number?
The American Heart Association has these Know Your Number campaigns, which is important. And things like total cholesterol, in particular, is what they focused on, being less than 200, and for more higher-risk individuals being less than that. And knowing that your LDL is less than a certain number. And those values depend on whether or not the person's inherent risk. And just, as you're mentioning this, I think that it's important for people to take a step back and realize that cholesterol is just one part of the bigger equation, and knowing your numbers really involves knowing the blood pressure, knowing the measure of your glucose in your bloodstream, knowing that exercising on a consistent basis is really an important number to know as well. So all of these things are kind of important, but that being said, knowing that your total cholesterol is less than 200 is certainly an important value to keep in mind.
And would you throw out a similar number or a similar benchmark for LDL? I mean, at what point would you say that's good?
Usually we like to see that LDL is less than 100, or in patients who have a higher family history or have had a heart attack or stroke, or we like to see less than 70, although that's changing. What I would say is that if you're concerned about your heart risk, you should be asking your physician what your ideal level should be, because it really does change based on the person's risk profile.
So let me summarize what you just said and see if this is right. It's important to know the number, but the number that you're aiming for is going to be different depending on whether you're a healthy 25-year-old or a 65-year-old who's got high blood pressure, diabetes, and a family history of heart disease.
That's right. And as I answer this, let me just put a quick plug in for the Lipid Center at the Northshore. I mean, this is where people refer patients with high cholesterol or not who just want to know whether or not they need cholesterol management. And as part of the evaluation, we aggregate their risk factors, and we give them kind of a heart score, a heart risk profile score, and that includes taking into consideration their own risk factors, their family history, as well as a variety of other blood tests, imaging tests, and then we offer kind of a customized treatment plan, including using a nutritionist and potentially basic medications to advanced medications. So we really try to customize it based on the level of risk.
That makes a lot of sense. And so we talked a little bit about dietary changes that people can make. You mentioned also that trying to maintain an ideal body weight and exercising regularly are important for managing lipids, cholesterol, triglycerides, et cetera. Are there other non-drug things that are important in this equation?
Definitely. So I believe that the role of diet and exercise in improving your heart, vascular health, maybe even preventing certain cancers is significantly underutilized. And I really believe that these are primary medications. The diet and exercise should be viewed as primary medications that we take every day. I'm also a big believer in a big proponent of routines. So I think that having a more global focus on how you're sleeping, exercising, eating, and reducing stress will go a long way than hyper-focusing on just cholesterol. So I guess that's my way of saying my recommendation is to focus on becoming a healthier individual and then go to your doctor to get your cholesterol levels checked.
So a more holistic approach to health than just kind of focusing on a particular number. Right,
with the exception of certain genetic disorders or in very high-risk individuals. I think that that global approach is really something that should be utilized more.
In those individuals in whom you've had this conversation, they're making those necessary changes to their lifestyle, but they're having trouble reaching their goal, or for whatever other medical reasons, you think they would benefit from a medication to help lower their cholesterol. Could you just speak about the major drugs available to lower cholesterol?
So most commonly people hear about statin medications, and that's because they're honestly the most well-studied medication of all time. These medications include names such as Lipitor or Crestor. For other patients, they may not be enough, and newer injectable medications called PCSK9 inhibitors like Prio or Repatha may be necessary. We also are looking in patients with diabetes, high triglycerides, or obesity, and there's a new class of drugs called SGLT2 inhibitors like Jardiance or Farxiga that really lower risk, glucose, as well as weight. And I'm also a big proponent of very specific fish oils such as Vasepa. And then when you get to more advanced cases, genetic cases, we have other therapies that are available, and going all the way to LDL apheresis, which we'll be starting at Northshore.
So just mention what that is.
So LDL apheresis is basically where we take someone's blood, we run it through a filter. It filters out all the LDL, and then we recirculate it back into the patient. And that's sometimes necessary for these patients with familial hypercholesterolemia who aren't reaching their goal LDLs despite being on a number of medications.
Yeah. I want to go back to the statins for a second. I mean, these are very widely prescribed medications. I think by some measure, they're the most widely prescribed medications in the country. I don't know if that's exactly right. Maybe you do. There's still, I find, and I suspect you do too, that there's some resistance among patients to take these medications because there's a lot of misinformation out there around side effects. And I wonder if you could just speak to the safety and efficacy of statin medications.
Sure. So this is an important issue. I'm glad you raised it. So statins are our primary medication in both reducing risk and lowering cholesterol, so the reducing risk of heart disease and stroke, that is. What I like to tell patients is that if you go on the internet, you'll find what you're looking for. So if you've heard from a friend or a relative that statins cause cancer or they cause you to lose your memory, all of these different things, well, you'll be able to Google statins and memory and find a website that confirms your worst fears. But really, what they've shown is that these kind of things, these fears such as statins causing cancer, kidney issues, Alzheimer's, they've all never really been proven, and the FDA has looked at this very closely and said there really should not be any concern. In fact, you have less risk of having vascular dementia by taking statins. That being said, statin intolerance is real. It can happen in about, in the studies, 10 to 12% of patients. And you really want to try to get be objective as possible with yourself. So that means that you'll want to know what kind of symptoms in your body, what kind of body aches you're having before you take the statin, and even sometimes document it, so that after you take the statin, you don't necessarily attribute your symptoms to it. But these symptoms of statin intolerance would be if you have kind of weakness or cramps in your upper arms or upper thighs, fogginess. These can be some of the different types of symptoms. And oftentimes we can resolve this in probably 80 to 90% of cases with different medications or even different dosing strategies.
So if I were to summarize what you just said, statin intolerance is a real thing, but it's a lot less common than you'd be led to believe by surfing the internet. And these are, in fact, exceedingly well-studied drugs that have a lot of positive benefits.
That's correct.
One last thing before we have to wrap up. How often should people be getting their cholesterol checked?
We recommend checking 3 to 4 months after starting a new treatment or changing doses. Otherwise, it's yearly.
And if folks want to get better information than just confirming their worst fears, as you said, are there sources of information that you would recommend as high quality and reliable that folks can check out?
I'd also encourage people, again, to reach out to my staff at the Lipid Center, just to, we're happy to see patients who just want to know whether or not they even need, more workup because of a family history, or whether or not they need to be on cholesterol medications to begin with. And we also have a lot of information about basics of diet and types of medications we could put people on. The National Lipid Association has a number of patient education resources as well, so I'd encourage people to check that out also.
All right. Ben, thanks so much.
Thank you, Ira.
My guest today has been Dr. Benjamin Hirsh. Dr. Hirsh is the Director of Preventive Cardiology at Northshore University Hospital and an Assistant Professor of Cardiology at the Zucker School of Medicine. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.